Great. Thank you very much to our speakers. I don't know if Dr. Merkin is in the room. Yes, we have a special treat for this session. Dr. John Merkin, who needs no introduction to this forum, who has been a strong proponent of less invasive techniques in coronary surgery for a long, long time, and one of the big propellers of OPCAB surgery back in the day from the University of Western Ontario in London. He's going to talk to us about minimizing neurological risk in coronary surgery. Dr. Merkin.
Well, thank you very much for a very nice introduction and a very nice opportunity to get back and speak with you all a little bit. I very much enjoyed the presentations this afternoon. I think there's going to be a certain amount of overlap and perhaps a slightly different perspective on some of these aspects. My disclosures, I've had the good fortune of not only being peer-reviewed funded, but of working relatively closely with industry, particularly talking about brain monitoring, near-infrared spectroscopy, and things like that. So just be aware that I have those kinds of considerations. You've heard this. This is the syntax trial, and I think this really puts it a fine point on it. As one knows, the overall results as far as major adverse cardiac or cerebral vascular events strongly favored coronary bypass. However, PCI has a significantly lower stroke rate, and that really was the takeaway message. PCI has a lower procedural stroke risk, but higher risk for angina, repeated revascularization. And really the question is, why is the stroke rate higher in cardiac surgery? So some of this stuff is clear, atherosclerotic emboli, but I'd like to talk a little bit as well about some of the other less apparent issues to do with hypoperfusion and this concept of panvascular inflammation. This is a paper that was done from the group in Japan a few years ago using epiaortic scanning. What they were able to show is that if you scan the aorta after instrumentation, cannulation, and clamping, you find that there's a very significant incidence of new intimal lesions. And this, again, would seem almost intuitive if you think about it. And this was correlated to the extent of atheroma. So the more atheroma that was instrumented, the greater the likelihood of raising an intimal flap or causing some form of ulceration. 30% of these patients went on to have an overt stroke. And this raises the question, as you know, about 50% of strokes are apparent relatively immediately on the patient awakening, and there's another 50% approximately that have a lucid interval of a period of days at which they then have a stroke. So are these things related? Well, this would seem to be one potential mechanism. You raise a flap, you have an intimal lesion in the ascending aorta, and this could give rise to delayed, either immediate or delayed neurological complications. And maybe part of the reason that some of the studies have been able to show that even postoperative aspirin has an impact to reduce stroke rate. Again, potentially mitigating some of this type of complication. You saw some of this data. This is from Emory. This was just a case control, patients that had a stroke versus patients that did not have stroke, looking at the various aspects. And what they showed is that patients on bypass, use of a single clamp seemed to significantly lower their stroke risk. Again, less instrumentation of the aorta. The other thing that I was struck by is their trend showing that in the last 10 years, this is 2002 to 9, I think it was, the incident or the usage of epiaortic scanning went from less than 50% to over 90%. And I remember being at the STS with Michael Mack on one of these panels, and we did a poll in the audience, and it was less than 10% of the surgeons present were using epiaortic scanning on any kind of a routine basis. So I think this is really a testimonial. This is an interesting paper. This is just one of these, a registry from Spain, 26,000 patients looking at stroke risk, comparing on-pump to off-pump surgeries, and found overall no significant difference in the stroke risk. However, when they looked at patients that had 2 or more risk factors, there was a significant reduction in stroke associated with off-pump surgery. And we know that. That's consistent with other data that's appeared out there. Very sick patients will often do better with a beating heart procedure. But, of course, there's a wrinkle. This is an interesting paper from a group in Seoul where they did beating hearts and used a partial clamp with or without epiaortic scanning. And what they showed is that in the subgroup of patients, which is approximately 25 to 30% of their population, they would put a side clamp on doing their beating hearts. If they used epi-aortic scanning, there was a significantly lower stroke risk than just blindly clamping the aorta. Again, if you can see and avoid plaque, you're better off, particularly doing a beating heart. And I think there's a difference between on-pump that we might have an opportunity to discuss later on. Of course, this is very similar to what Antonio Calafiore, I remember presenting this at the ISMICS meeting in Helsinki a number of years ago. And he'd reviewed his experiences, about 5,000 patients, 2,000 beating hearts, 3,000 on pump. And the overall stroke rate was about 1%, clinically overt stroke. Half were early, half were delayed, very consistent with what we see in the literature. What he found was if you do beating heart and you use a partial clamp, the stroke risk was the same as going on bypass. So all these things are saying the same thing, that a blind clamping on the aorta is potentially another significant risk factor for atheroemboli. Hypoperfusion. Do we need to do carotid endarterectomies on our patients who have significant but asymptomatic carotid lesions before having heart surgery, because we know that stroke is a particular concern? This is one of many reviews now. This is a meta-analysis from Ross Naylor, a vascular surgeon in the UK. He used to come to our outcomes meeting. It did this very nice review, and their overall impression was that there's no evidence that doing a coronary endarterectomy, either staged or sequential, will lower your stroke risk, unless the patient has overt symptomatology from their carotid stroke. So a prophylactic endarterectomy does not seem to be beneficial. However, hypoperfusion may be a significant issue, and this is new data now coming out looking at cerebral autoregulation in real time and using the correlation between transcranial Doppler or near-infrared spectroscopy and looking at the correlation on a weighted average over time between mean arterial pressure and TCD or NIRS. So if they correlate, if the things go up when the blood pressure goes up, then you've lost autoregulation because flow should be independent of mean arterial pressure over a long range of pressures. So they could define impaired cerebral autoregulation. Patients who had impaired cerebral autoregulation had a significantly higher stroke risk than those patients who did not. And that was found in about 20% of the population, which again isn't surprising. Atherosclerosis is a systemic disease, cerebral vascular disease, may be occult, but is a significant burden. So 20% of patients don't autoregulate well. So what is the appropriate pressure during bypass? This is the same group, a larger series now, 450 patients, again looking at autoregulation. And what they found, there was no interventions. They were just simply determining whether or not these devices picked up the patient is autoregulation or they're significantly below it. And looking at the area under the curve, the more time you spent when the patient was inadequately perfused, the greater the risk not only of stroke, but of major adverse outcomes, because of course all the organ systems are potentially suffering if the brain is, and other organs by extension, are being hypoperfused. That's not too dissimilar to what we showed a number of years previously. We just used a cerebral oximeter, measured oxygen saturations, and kept the patient's baseline oxygen saturation in the same range. And we have a whole paradigm for how you actually do that. But what we showed, and at the time it was quite controversial, we showed that by monitoring the brain and optimizing brain perfusion, we had a better result overall in the patients. Their kidneys, their gut, all of the other complications, major organ morbidity and mortality was significantly reduced. And it's not that 11% was so bad. The STS database has these same parameters, about 13%. So we actually improved outcomes with a trend to reducing stroke. We weren't powered for stroke. But so all these things are sort of consistent. We need to be able to adequately perfuse patients, but what is the right perfusion pressure? This last concept is panvascular inflammation. Even if you do all these things, we still know patients have stroke. And this is not the patients that have atrial fibrillation or an obvious stormy hemodynamic course. These are patients that we just can't figure. Why did this patient have a stroke? I think there's a lot of new information now coming out looking at plaque activation, this concept of panvascular inflammation. This is one of the studies, I think, from an Italian group. They looked at about 350 coronary patients. About 64% of them were felt to have significant carotid plaques. The patients that had unstable angina had a significantly higher C-reactive protein on blood analysis, and that was associated with a higher likelihood of having a complex plaque, that their carotid plaques are ulcerated or other ways of determining that these are fractured or otherwise unstable. So in the patients with carotid stenosis, if you have unstable angina, there was virtually a 10-fold increase in the likelihood of any incident, even if they're asymptomatic, incidental carotid plaque being activated, potential. Similar kind of study, this is from the UK. They looked at patients awaiting coronaries. Again, all these are asymptomatic who have incidental carotid stenosis, and 10 patients not waiting heart surgery who just have incidental carotid stenosis. Did an MR assessment of their carotid plaque. And what they were able to show is that the patients awaiting coronary bypass, the likelihood of this plaque being activated, of having fractures or various other phenomenon, was significantly higher in the patients with clinical coronary atherosclerosis, patients that are symptomatic. So these patients had the actual cross-sectional area was less, but the severity of the inflammation in their plaque was greater. These plaques are active and potentially at risk. This is just some data from the group at Duke, along with many other groups, ourselves. We've been looking at some of the phenotypic makeup of patients. They were able to show that patients that have an allele that predisposes them to a greater inflammatory response, IL-6 C-reactive protein, that these patients have a fourfold increase in risk of stroke at any time. Again, likely the same phenomenon, that their plaque becomes activated. And I recently had the opportunity to collaborate now with some colleagues in Seoul. They have a very extensive database, and they looked at 1,000 OPCAB patients. They have data, they had daily CRPs, they have all of the blood work is done quite rigorously and intensively during their operative stay. And they showed that there was a correlation between their C-reactive protein and their lactate and base excess intraoperatively. So if you had evidence of hypoperfusion, your lactates are going up, your base excess is, you got a negative base excess, they're not perfusing well, they had a likelihood to have a higher CRP. You've set off the inflammatory processes. And that this was associated with long-term major organ morbidity and mortality. Interestingly, in the patients that were on statins, even though the CRP may be higher, there was a lower stroke risk. And so the statins in this population, again, seem to have some protective benefit. And of course, as you're aware, that's entirely consistent with what's in the cardiology literature. That is this association with statins as a general sort of anti-inflammatory type activity. And there's been shown that patients who are on statins tend to have a lower stroke risk in other fields. The overall summary then would be epi-aortic scanning. Blind manipulation instrument of the aorta is not necessary. We have the technology, we just need to get the application. A single cross-clamp device, again, the less manipulation of the aorta one can do, the better as far as the potential for liberating atheroemboli. If one's going to do beating heart, and we certainly advocate that, then the benefit is obtained using scanning. You want to know where you're putting a side clamp on, or a no-touch. I think we're now really starting to understand over the decades, there's been all kinds of literature on anti-inflammatory, inflammatory processes, et cetera, et cetera. It doesn't seem to have any real impact on outcomes, but I think we're starting to target that down better. And I think we can see that anti-inflammatory strategies, particularly in subsets of patients that are at higher risk may have a significant role to play, whether it's even on bypass, heparin-bonded circuitry, other techniques to reduce inflammation may well be beneficial. And lastly, I think, again, the ability to monitor perfusion in real time really does enhance the ability. So I'd like to thank you for your attention, and if there's any questions, I'd be happy to discuss it.
Thank you, Dr. Merkin. Excellent presentation. Any questions for Dr. Merkin? Alan?
Great to hear you again, John. Some of your early work on cognitive dysfunction, can you just relate a little bit of the last component, the inflammatory stuff, to that, and what your thoughts are now?
Yeah. I think, first of all, we did a lot of, as many other groups are doing, cognitive outcomes, and I think that literature got pretty muddied. I think the best role, because what is dysfunction? We have to arbitrarily set a threshold, and because in the literature there's all kinds of thresholds, it's very difficult to add things up. I think the primary role for cognitive testing in general is to compare one group to another group. You're not trying to look at the absolute incidence of cognitive dysfunction. You're just trying to say, these are some measures of brain function. Does one group do better than the other? The evidence suggests that one can use that to discriminate surgical techniques, and that there is a role of inflammation and emboli magnitude, the numbers of emboli that one sees using both cognitive testing and with MR spectroscopy, one can pick up new lesions. And I think these things are exacerbated if you have a heightened inflammatory response. I had a bunch of other slides. We know that patients that have stroke, patients that have even these hyperlucencies, there's generally an associated influx of leukocytes into that area. So these are inflammatory processes, and if you have an ischemic insult, the greater the inflammatory response, your patient getting hyperthermic. We know hypothermia is protective. 1 degree of hyperthermia, patient gets febrile postoperatively, and one can show experimentally that the size of the infarct increases exponentially. So inflammation and its impact on any particular ischemic insult is quite significant.
I had a question for you. This issue of dual antiplatelet therapy in comparing PCI to surgery and the stroke risk comes up very frequently. We heard it today. A lot of us moved towards using 6 to 8 months to 3 months, 6 to 8 weeks or 3 months of antiplatelet therapy in OPCABs to prevent DVTs and whatnot because the platelets don't get beat up. Do you think that that would be a strategy for us to do to prevent some of these local tears that you've been demonstrating on the side-biting clamp to prevent the delayed strokes?
I think so. I think that was, at the time it came out, I was very impressed with that paper. There hasn't been a follow-on. I think, Emory doing 90% plus scans, any of the centers, that'd be something to look at. Just look and see after, first of all, what is the incidence? If this is correlated, which it would seem to be, that makes perfect sense to me. And when I saw that, I thought that really shines a light on these delayed strokes. Anecdotally, we know of patients where we've seen mobile plaque or ulcerations, and the patient post-operatively does have an adverse outcome, has a stroke or something else. Mm-hmm. You can have gut ischemia depending on where it goes. So I think that's how I can bridge that. There was an early aspirin paper I alluded to in 2004 that showed a reduced stroke rate. I think that's exactly what it is. We need to do something. It's not just the heart-lung machine or not just the perioperative interval. It's a period of time at which these patients are at risk, probably several weeks at least. I would say. Just incidentally, I've always struggled, years ago with Alan and others, we were doing a lot of aortic scanning. Looking at the literature, I really can't make a compelling argument as a generalization that for on-pump surgery, epi-aortic scanning has dramatically reduced the stroke rate, which is what I would have predicted. Why is that? And yet off-pump, it's clear. Off-pump, you should scan the aorta. If you're going to go to all that, I think very good work to do a patient beating heart. If you're going to clamp the aorta, scan it. Why? I suspect it has to do with the aortic cannula. When we cannulate those patients, the velocity that's coming out of that aortic cannula is 400% greater than what comes out of your aortic valve. So we're now sandblasting, and we know that if you've got a plaque in your descending aorta, you've got a 40% likelihood in the ascending and significantly in the arch. So I think on pump, while you can avoid direct plaque, when we then cannulate into the ascending aorta, if there's plaque in the arch, all of your work is necessarily for naught, because now you're going to sandblast that. And I think that's, I haven't got a lot of evidence, but I suspect that's what's going on. And I think it's time to revisit aortic cannula and the types of flow velocities we're using on patients on pump.
Just let you make a comment. You know, it's a paper from Toronto from a number of years ago where they compare a distal ascending aortic cannulation versus arch. And 40 patients, nobody had a stroke, but they looked at transcranial Dopplers. And the patients, of course, that had a distal ascending aorta had many more hits than patients that you cannulate the arch of the aorta. So personally, I tend to cannulate beyond the head vessels as much as one can do that, because, you know, it's one of the potential elements to prevent a stroke.
And in the same way, I think that's why there's some evidence that, you know, subclavian, if you're perfusing through the subclavian artery rather than the arch directly, I think you tend to diffuse that instead of it going right up into the patient's brain. Goes elsewhere, but still, I think that's potential mechanisms.
Since I'm here, let me ask you another question, because, you know, we wrote a paper 4 years ago where we looked at on pump and off pump. And I'm going to say it bluntly, I always felt that when I gave a patient a stroke on cardiopulmonary bypass, I gave him a worse stroke than when it's happened off pump. And so we went and looked at, at the complexity of the stroke, not just stroke as a number. And well, we could have looked at 60 or 70 scans that we didn't, but, you know, one thing that we notice is that when the mortality for stroke, if you use mortality as a marker of complexity of the stroke, it's about 20%. This is in the medical literature, in Hopkins data, and so on. When patients had a stroke off pump, we had a reduction of 84% in the mortality for stroke. So the strokes were relatively benign, you know, and the patients recuperated from them. Any comments? Well,
I think that the hydrodynamic, non-pulsatile endocrine changes associated with cardiopulmonary bypass are significant. And I think most patients can tolerate that. But I think when we start to have patients that are at risk or more susceptible, these differences have an impact. I can't tell you persuasively that the inflammatory response is greater on bypass, but I believe it is, depending on which sort of markers you're looking at. But I think the fact that with beating heart surgery you have a more, quote, more normal perfusion, I think that helps presumably preserve whatever brain flow there is. But certainly this concept of inflammation, you've had an insult, and you can't do much about that. It's happened. But now how that is dealt with, the amount of inflammation, which is a component of potentially on-off pump, temperatures, and the patient's own inherent amount of CRP, the inflammatory response the patient manifests and the inflammatory response he comes into the operating room with, will all influence their susceptibility to these insults. So I think that'd be very interesting if you publish that data. I think that'd be a very interesting paper because it makes you think about different components.
A large number of patients routinely at a number of institutions get preoperative carotid duplexing.
Yeah.
It seems to me from what you presented today that this is really a waste of money and a waste of time based on...
You know, one doesn't want to be absolute. It's all relative. But I would say yes. You know, there's been, as you know from the literature, the association between carotid plaque and stroke is significant. If you've got carotid plaque, there's no question you're at a higher risk. But I think that just is showing that you have probably bad aortic atherosclerosis and everything else. It's a marker rather than a mechanism per se. You know, I think, and that's what, so I had Ross Naylor, he was down at our outcomes meeting a few years ago, give a very nice review of this whole area. He's a vascular surgeon, this is what he does for a living. But his take on this is that it is not warranted. There's no evidence, and I reviewed this just before coming down, there's still no current evidence that doing a carotid endarterectomy is going to prophylax your patient against having a stroke. They definitely got a higher risk, but doing an endart is not necessarily the way to approach it. Unless they're symptomatic, that's a different deal. But if it's asymptomatic, there's no evidence. However, I should qualify that. I think the other part to that thing is, you know, this patient's also got impaired cerebral autoregulation. And that's what Chuck Hogan, the guys at Johns Hopkins are showing, that if you measure cerebral autoregulation, 20% of the patients on bypass in their study don't autoregulate very well. And sometimes it's way over 90 mean arterial pressure. They get below that, they start to lose their autoregulation. So now this patient has been hypoperfused for 60, 90 minutes, however long it is. They've got carotid stenosis, but they've got bad autoregulation. It's not this that, because most of the papers that have been done with carotid endarts, they've had a stroke on the other side. So it's true and unrelated. But they've probably got bad autoregulation. And we didn't get into all the other stuff. It's not only mean arterial pressure, but lifting up the heart to do distal anastomosis, your venous pressure goes way up, so your perfusion pressure is in minus out. We all watch the inflow. Well, if your outflow pressure is high because the heart's lifted up and your SVC is compressed, there's still not a lot of flow going up to the brain. And that's what we showed with the cerebral oximeter. So there's a bunch of things to this, but we can start to look at it as we understand the mechanisms.
Thank you very much, Dr. Merkin. That concludes our session for this afternoon. We have a break until 4, and then the TVAR session.